Now, questions to identify simple common diagnosis. When I talk about this face-to-face interaction, yes, it can be over video, but first thing you can ask the patient to demonstrate the cough, because sometimes some patients, even they think this is cough. This is not cough. This is just a throat clearing. So you have to differentiate this between this throat clearing and a genuine cough. So it is just the medical school training, but we don't do that nowadays, but that helps us a lot. When this cough started, was there anything happened before? Like, has it started after COVID? Has it started after some infection or any surgery or anything? What is the timing of the cough? Say whether there is any diurnal variation. Like we all know that asthmatic cough shows some diurnal variation. The other coughs, there might not be, or GRD cough, they can aggravate after meal. Is it better at weekends? Occupational asthma, as we already just discussed. Cough after meals, GRD. Any triggering factor that has the patient had any COVID infection, whether they smoke, whether they take any medicines, or is it bad after an exercise? We all know this entity that exercise induced asthma, and seasonal variation and frequency, which we are seeing at the moment. The other symptoms, when we talk about this, is very important. When we talk about the cough, first thing we ask, is it a dry cough or a wet cough? Are you bringing up anything? If you are bringing up anything, what is the color and what is the volume? Are you bringing up just a small amount, or you are bringing up a good amount? What is the color of the flame? Is it white? If in the COPD, we know can give a lot of white flame. But when it is greenish or yellow, we have to think about, or whether it is blood tinged. Is it associated with any shortness of breath, or just the cough is bothering you? Any chest tightness along with it? Any wheeze at night or in the daytime also, any nasal symptoms associated with like runny nose or blocked nose, or repeated throat clearing as I have demonstrated. Non-respiratory symptoms, is there any acid reflux or in a face and facial area like sinusitis? When I say that acid reflux or heartburn, we always think that GERD is always associated with acid reflux, but there are two types of GERD. One is associated with acid reflux, another is not. So I will come to that. Smoking. When you are taking the history of smoking, so sometimes we ask, do you smoke? They say no. Ever smoked? Maybe they have left it 3 days ago and they are feeling very happy that they are not smoking anymore. So how many they have smoked so far? And always they will say when they are coming with cough, I've reduced it or I have left it. So left it perhaps 3 days ago, reduced it from say 10 to 6. So you have to take the history. Consider these conditions apart from neoplastic things. Drug history, when you are talking about drugs, two types of histories you have to take. What they have already used so far for the cough, because here we are talking about chronic cough. Maybe they have used some antibiotics. If you are repeating those antibiotics, it's useless. And in our country, we can get the antibiotic over the counter without any prescription. And also they have their your old prescription or some doctor's old prescription with them. They just repeat the medicines. Inhalers. When they talk about inhalers, always ask which one, how are you using? Is the inhaler with you at the moment? If they have, just check how they are using it. That's also very important. Use of drugs for other conditions. Again, I will elaborate that because this is a very important area. I'm coming to that. History of allergy, we all know, and not only patient's history, it's history of the family of asthma, family history of allergy and asthma, and particularly nowadays, history of COVID. And impact on daily life. This we hardly ask nowadays because we don't have time. Now, cough, this chronic cough can affect patients very badly in different ways. One is maybe they are in a profession where they have to use their voice a lot. if they continuously cough, say they're working in a BPO or over the phone, so online something. So if they're continuously coughing, definitely it's not a good thing for them. In other state, in other cases, there are two more conditions you have to think about, particularly in a bit of elderly women. It's about incontinence, urinary incontinence. So that is very important, that whether they are becoming incontinent while they're coughing. So the stress incontinence I'm talking about. Another is cough syncope. If cough is violent, if they have any history of cough syncope, they should avoid using any machinery or drive, or they should not drive, or even they should not go in front of the fire. So that is why this impact on daily life of cough, it can go to that extent. So you have to ask this question. Stress can aggravate cough, and cough can aggravate stress. So it's a vicious cycle. Occupation, we have mentioned again and again, and past history of any gastric or biliary surgery.